Hi, this is Brian Kim. I'm going to share with you case number 51 in the best way to do cataract surgery series. This is a moderately dense lens, and I'm going to show you double chop, cross chop, mechanical fracturing, and also showing you how I maximize using the chopper to my advantage by pulling pieces up out of the bag and crushing the lens pieces. This patient also had negative dysphotopsia in his first eye, and so for this eye, I decided to do a reverse optic capture to minimize the negative dysphotopsia. So I'm using a cotton tip to hold the eye steady, and then I use a corneal marker to help me center and size the rhexis. I'm using the cotton tip to help stabilize the eye and turn the eye, and I'm making my paracentesis incision, making sure I have a flat approach and parallel to the iris plane. Do the same thing on the left side, making sure I'm flat to the iris plane so I can have a very nice corneal shelf, which will allow me to help get a self-sealing corneal incision. I'm injecting some intracameral lidocaine and then some dispersive viscoelastic. I'm using the cannula to hold the eye steady, and then I make a vertical groove for my triplanar corneal incision. I place the blade into the deep part of the groove, turn the eye using the cannula, and then I tunnel through the cornea, bring the cannula back towards me, and then enter, and that's the triplanar corneal incision. This is the puncture style Capsulorhexis. I go in with the teeth sideways, and I puncture centrally with the forceps. I pull towards me, and then I'm going to grab the right edge to create a flap. I want to make sure the rhexis is smaller than normal since I'll be doing the reverse optic capture technique. And so that's another nice thing about using the corneal marker. It helps make sure that I get a small enough size rhexis so I'll be able to achieve that reverse optic capture without trouble. Go ahead and finish off the rhexis and burp some viscoelastic. This is the Capsular Fornix Hydrodissection technique. Place the cannula out to the equator, contra-incisionally, point the tip down, you get a nice fluid wave, decompress on the left side, and I'm able to spin the lens from the right side. Go ahead and irrigate the surface of the cornea, and then I'm going to lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. And then I'm going to remove the surface epinuclear material. Place the chopper underneath the epinuclear ridge out to the equator. Place the figure tip vertically subincisionally. Crush the lens by bringing both instruments together. That's the double chop. Place the chopper out to the contralateral equator, pulling it centrally towards the figure tip, crushing the right heminucleus in half, and that's a cross chop maneuver. Use a little bit of vacuum and place the chopper around the lens piece, crushing that first quadrant, and then pulling the lens pieces up out of the bag. I'm going to use mechanical fracturing forces as well as vacuum and some phaco energy. Go ahead and place the chopper around the second quadrant, pulling it centrally, crushing the lens piece in half, and then using vacuum as well as mechanical fracturing forces to emulsify the lens pieces. Turn the second heminucleus in front of me, place the chopper out to the equator, pulling it centrally, crushing it against the phaco tip, dividing that second heminucleus into a third and fourth quadrant. Place the chopper around that third quadrant, pulling it centrally, crushing it against the phaco tip, using mechanical fracturing forces to crush the lens pieces into smaller pieces, and then using vacuum as well as ultrasonic energy. This is the last quadrant. Place the chopper out to the equator. Around the lens is trying to tilt, and so that's why I'm having a little bit of trouble. I try again, and I'm able to get around the lens piece, pull it centrally, crushing it against the phaco tip, using a little vacuum to manipulate the lens, crushing it with mechanical fracturing forces, and then emulsifying the lens pieces. So this is the last fragment. Place the chopper around the lens, crushing it against the phaco tip, and then crushing it again with multiple mechanical fracturing maneuvers, and using a little bit of vacuum and ultrasonic energy, emulsify the lens pieces. And this is really that last piece. I'm crushing it, again using mechanical fracturing forces, and ultrasonic energy and vacuum. So the endonucleus is out. I'm going to remove the epinuclear material now, making sure the chopper is deep to the bag. You can see there's a big chunk underneath me, and rather than using the phaco tip, you see I use a chopper very nicely and manipulate that lens piece up out of the bag, positioning in a way that I can emulsify the lens pretty easily. So I take the chopper out, push BSS in, take the phaco tip out, and then put the INA handpiece in. I start sub-incisionally, removing the cortical material from anterior to posterior, peeling off the lens pieces, and then going around circumferentially. And then I switch to the polish mode, polishing underneath the rhexis edge. Also polish the posterior capsule surface. It looks pretty clean. I'm going to use BSS cannula to pulse the subincisional capsular fornix just to make sure there's nothing else in there. Looks pretty clean. I'm injecting some cohesive viscoelastic to fill the bag. And then I'm going to use the sweep to polish underneath the Capsulorhexis edge. First on the left side and then on the right side. With some of these dense lenses, I like to put in a 3-piece lens instead of a 1-piece. I feel like it provides better zonular stability, and in the case of future zonular problems, you can use the 3-piece haptics and suture it to the sclera. I'm injecting the 3-piece acrylic lens into the capsular bag, and then I'm using the Maltzman to dial the trailing haptic into the bag. I go in with the INA underneath the lens, remove all the viscoelastic from within the bag. But again, I'm going to do the reverse optic capture here. So I'm going to use my Maltzman to help me control the optic. So I'm just teasing it up towards me. And once I get around the rhexis edge, I'm able to lift it up anterior to the rhexis edge. And now I was able to achieve the reverse optic capture. So I remove the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So you can see the reverse optic capture provides this cat eye appearance to the anterior capsule. You can see the optic is anterior to the rhexis edge while the haptics are still inside the bag. You can see where I use the Maltzman to manipulate the lens. There's these little small marks, but that will be gone by the next day. So I go ahead and hydrate my incisions. So you can see this is a fairly dense lens. I use double chop, cross chop mechanical fracturing techniques. I had a stubborn piece of lens material that was in the subincisional capsular fornix. I used a chopper to help easily manipulate that lens piece up out of the bag. And then I did a reverse optic capture using a Maltzman to help me tilt the lens so I can prolapse it up out of the bag. Variety of techniques for this case, and the patient did well with no negative dysphotopsia. So I hope this was helpful to you, and I thank you for your attention.